Flank pain and hematuria, two symptoms you'll encounter time and time again on test day. But can you confidently differentiate between nephrolithiasis, renal cell carcinoma, and renal papillary necrosis? Today, we're going beyond the basics. In this deep dive walkthrough, I'll not only help you ace this question, but also arm you with high-yield renal pathology details that most students miss. Let's elevate your clinical mastery. Welcome back to MedUPTICK Physicians in Training. Renal pathology is a high-yield topic on the USMLE, and mastering it is key to your success. Today, we'll tackle a challenging vignette step by step along the way. I will share advanced insights into renal pathology that will stick with you long after exam day. Which of the following is the most likely cause of this patient's condition? A 65-year-old man with a history of type 2 diabetes mellitus, hypertension, and chronic lower back pain presents to the emergency department with dark-colored urine and severe left flank pain for the past 2 days. Here are some key clues. Dark-colored urine likely indicates gross hematuria, though pigmenturia, such as myoglobinuria, should remain on the differential. Next, severe left flank pain localizes the issue to the renal or urinary system, making nephrolithiasis, renal infarction, or pyelonephritis top considerations. Diabetes and hypertension are strong risk factors for vascular complications, ischemic kidney injury, and structural changes to the renal system. Here is a high-yield insight. Diabetes leads to advanced glycation end products, abbreviated to AGEs, which contribute to renal vascular damage. This makes diabetic patients more susceptible to ischemic injuries like renal papillary necrosis. He reports frequent use of ibuprofen for back pain. This is another key clue. Chronic NSAID use reduces prostaglandin synthesis, impairing medullary flow. This predisposes the renal papilla to ischemia and necrosis. The high-yield insight is prostaglandins play a critical role in maintaining afferent arteriolar dilation in the kidneys. Without them, the renal medulla, already poorly oxygenated, becomes highly vulnerable to ischemic injury, especially in patients with underlying comorbidities like diabetes. He denies fever, chills, or recent infections. Although only a brief statement, this sentence is another key clue because the absence of fever and chills argues against an infectious process like acute pyelonephritis. A high-yield insight regarding pyelonephritis is it typically involves an ascending infection originating from the bladder. Examples include pyelonephritis due to Klebsiella pneumoniae and Proteus mirabilis, both associated with urinary catheters and structural abnormalities. A positive urine culture is almost always present. On physical examination, his temperature is 37 degrees centigrade, blood pressure 145/90, and there is mild tenderness over the left flank without costovertebral angle tenderness. The key clues further support our thought process thus far. Normal temperature and no CVA tenderness reduce the likelihood of infection. Hypertension is a common finding in chronic kidney disease or renal vascular conditions. The lack of CVA tenderness is a significant high-yield insight because it points us further towards structural or ischemic causes of renal injury. Laboratory findings include hemoglobin 12.5 grams per deciliter. He has mild anemia, possibly due to chronic disease or subclinical blood loss. Serum creatinine 2.0 milligrams per deciliter, elevated from a baseline of 1.2. The 67% increase in creatinine from baseline could be indicative of an acute kidney injury. This is suggestive of acute insult like ischemia, obstruction, or nephrotoxicity. Blood urea nitrogen 30 milligrams per deciliter. According to the NBME, the normal BUN range is 7 to 18. The elevated bun to creatinine ratio is consistent with pre-renal AKI or ischemic injury. Urinalysis, gross hematuria, no red blood cell cast, no proteinuria. Gross hematuria suggests bleeding within the urinary tract. Common causes include renal papillary necrosis, nephrolithiasis, and malignancy. The absence of red blood cell cast or proteinuria rules out the diagnosis of glomerulonephritis, such as rapidly progressive glomerulonephritis or other glomerular pathologies, like class 3 and 4 of lupus nephritis or focal segmental glomerulosclerosis. To learn more about focal segmental glomerulosclerosis, check out this video. Urine culture no growth. Finally, a negative urine culture in combination with the absence of systemic symptoms such as fever excludes infectious causes like urinary tract infections. Which of the following is the most likely cause of this patient's condition? Based on the detailed analysis of this question, we are left with only a handful of differentials. Bilateral obstruction or solitary obstructed kidney, a bleeding source in the kidney like angiomyolipoma, but that is likely a zebra without any supporting details such as a genetic disorder or tuberous sclerosis. An extrauretic cause like retroperitoneal fibrosis, very unlikely. And at the top of the list, renal papillary necrosis. Let's start eliminating answer choices. A. Acute pyelonephritis. As mentioned previously, we can readily eliminate this answer choice because the patient is afebrile, denies chills, and is negative for CVA tenderness on physical examination and pyuria on a urine analysis. All hallmark symptoms of pyelonephritis. The patient lacks systemic signs and has a negative urine culture, ruling out infectious etiology. B. Glomerulonephritis. Although this patient presents with hematuria, which is present in glomerulonephritis, he lacks other common clinical symptoms, such as proteinuria and red blood cell cast. Additionally, most glomerular diseases are also associated with hypertension and chronic kidney injury, not acute AKI in isolation. Hence, we can eliminate answer choice B. C. Renal papillary necrosis. Chronic NSAID use and diabetes are classic risk factors for renal papillary necrosis. As noted previously, the mechanism of prostaglandin inhibition leads to medullary ischemia, resulting in papillary necrosis and sloughing. Hematuria, flank pain, and acute kidney injury are also hallmark features strongly supporting this diagnosis. So this is the most likely correct answer choice. D. Renal cell carcinoma. Renal cell carcinoma causes flank pain and hematuria, but patients typically present with systemic symptoms such as fever, unintentional weight loss, palpable flank mass, and risk factors like chronic smoking and or alcohol use disorder or genetic mutations like von Hippel-Lindau syndrome. Without these additional findings, renal cell carcinoma is unlikely to be the diagnosis for this patient, eliminating this answer choice. And E. Nephrolithiasis. Kidney stones are a common cause of hematuria and severe flank pain, renal colic, that often radiates to the groin, testicle, or labia, associated with nausea and vomiting. However, the history of NSAID use in the vignette and the lack of imaging evidence for stones favor renal papillary necrosis instead. In conclusion, C, renal papillary necrosis is the best answer for this clinical vignette, concluding this USMLE-Style deep dive walkthrough. Want to ace renal pathology? Here's your next step. Download our free renal papillary necrosis high-yield PDF packed with clinical pearls and advanced insights. Hit that like button if you found value in this detailed walkthrough and drop your biggest takeaway in the comments. And don't forget, subscribing to MedUPTICK means you'll never miss another high-yield question breakdown. Plus, one lucky subscriber will win our giveaway, prize valued at over $400 once we hit 500 subs. Until next time, stay sharp and focused and continue to elevate your clinical mastery.